Hello again. We're back for the fourth and final of 4 segments on antidepressant pharmacology. And in this session, we're going to focus on the more recently introduced antidepressant agents. There are a couple dozen of so-called newer antidepressant agents, and these have been clustered in several groups according to what we think are the major mechanisms by which they produce their antidepressant action. However, their pharmacology is both complex and continuing to be understood. So please recognize that these individual groupings are evolving, and both the groupings and the titles of the groups could change in the future. First of these are the SSRIs, the selective serotonin reuptake inhibitors. And these agents were rationally developed in an attempt to limit the toxicities seen in the MAOIs and the TCAs. Fluoxetine, Prozac, was the first of these to be marketed in the United States. The SNRIs, serotonin norepinephrine uptake inhibitors, have varying degrees of reuptake inhibition for each of the 2 monoamines. The serotonin modulators and stimulators simultaneously modulate one or more serotonin receptors and also inhibit the reuptake of serotonin. For example, vortioxetine Trintellix combines serotonin 1A agonist activity with antagonistic actions, blockade, at serotonin 3 and 7 receptor subtypes. Vortioxetine also inhibits serotonin reuptake. Varying additional mechanisms are found in the last group, which we'll unimaginatively call the tetracyclic unicyclic group. Mirtazapine, Remeron, for example, has alpha-2 adrenoceptor blocking action in addition to other actions on monoamines. Finally, we'll present 3 new agents that work very differently and more rapidly from all of the previous antidepressants that we have examined. The SSRIs, typified again by fluoxetine or Prozac, inhibit serotonin reuptake at concentrations that are several-fold lower than that required to affect reuptake of other monoamines. Behaviorally, they tend to cause excitatory effects, and sexual dysfunction is prominent. Because they elevate synaptic serotonin levels, the potential for causing the serotonin syndrome, especially when combined with other agents, is significant and needs to be recognized in pairing agents. The serotonin and norepinephrine reuptake inhibitors, the SNRIs, reduce reuptake of both serotonin and norepinephrine, although to varying degrees among the various agents. As with the SSRIs, they tend to cause behavioral excitatory effects. And in fact, there is a withdrawal or discontinuation syndrome that has been associated with the termination of therapy with both the SSRIs and the SNRIs. This withdrawal discontinuation syndrome is generally characterized by behavioral excitatory and somatic symptoms. One of these agents that we'll focus on specifically, venlafaxine, has been associated also with significant elevations in systemic blood pressure and need to recognize and monitor blood pressure in patients given venlafaxine. The serotonin modulators and stimulators have complex, largely serotonergic pharmacologies, combining serotonin reuptake inhibition with both stimulatory and inhibitory actions on serotonin receptor subtypes. Behavioral sedation is prominent in these agents, unlike the SSRIs and the SNRIs. Trazodone, for example, has often been used as a sleep aid in addition to its action as an antidepressant. GI distress and postural hypotension are noted with some frequency with the SMSs. And finally, nefazodone or Surzone has been linked to a specific hepatotoxic syndrome. The tetracyclic unicyclic group is something of a grab bag of pharmacology. The agents, that, as you can see in this slide, have widely varying individual pharmacologies. Bupropion, for example, inhibits dopamine reuptake more than it does norepinephrine reuptake. This has been used effectively in smoking cessation in addition to its antidepressant efficacy. It's important to recognize that bupropion, behavioral stimulation, and weight loss can be notable. The second grouping, amoxapine and meprotilene, inhibit both serotonin and norepinephrine reuptake and also show strong antimuscarinic actions. Overdoses present similarly with those of the TCAs. Seizures are prominent with meprotilene, and Parkinsonian-like symptoms are seen with amoxapine. Brexpiprazole, next agent, is a serotonin dopamine activity modulator, sometimes referred to as SDAM. It is a D2 receptor and 5-HT1A partial agonist, and it is a strong inhibitor at 5-HT2A, noradrenergic alpha 1B and 1C receptors. With brexpiprazole, weight gain and akathisia are prominent side effects that have been recorded. Mirtazapine, the last agent in this unwieldy group, tends to be associated also with weight gain and sedation. It is an alpha-2 adrenoceptor antagonist that causes both norepinephrine and serotonin release and blocks 5-HT2 and 5-HT3 receptors. A challenging group of agents to pull together under any one grouping. A generalized concern with antidepressants is weight gain. This effect can be seen in members of several antidepressant groups, and this effect can be of significant consequence to patients and complicate compliance with a drug regimen. In contrast, there are two agents, bupropion and venlafaxine, whose use tends to be associated with weight loss and can be associated with anorexia. The distinction between weight gain and weight loss among the antidepressant agents is an area of some significance. The final group of drugs that we're going to discuss today are agents that have been introduced recently and in common have been shown to exert antidepressant actions with an onset of action that is much more rapid than that associated with the drugs that we have discussed already. And often within a day or two of starting treatment, antidepressant actions can be seen with these drugs. The first of these to be recognized was the NMDA receptor blocker and dissociative anesthetic ketamine. Ketamine has been found to be an excellent analgesic at doses much less than those that cause dissociative anesthesia. Similarly, these doses have been shown to rapidly improve affect in at least some patients with MDD. That has led to the development of the S plus enantiomer of ketamine, esketamine, which is now available clinically as Spravato. This Spravato is available as a nasal spray. It is indicated for the use in MDD, and in addition, it is approved for use in combination with an oral antidepressant for management of treatment-resistant depression. It can be associated with some degree of dissociative behavioral effects, nausea, vomiting, sedation, and dizziness. The final agent, brexanolone, Zulresso, is an aqueous solution of the neurosteroid allopregnanolone. And allopregnanolone is an allosteric enhancer of the function of inhibitory GABA-A receptors. In postpartum depression, it's given by intravenous infusion over a period of several days. Sedation, dizziness, and dry mouth are side effects of brexanolone that have been noted. It is not yet entirely clear how the modulation of GABA-A receptors plays into an antidepressant action. However, the evidence is there for that effect. As a broad overarching summary of our 4 lectures on antidepressant pharmacology, please consider these key points. While monoamines in the brain do influence mood and well-being, we are learning that both glutamatergic and GABAergic systems can also be manipulated to positively influence mood in depressed patients. You recognize that the pharmacology of individual antidepressant agents is frequently complex. This can lead to frequent adverse effects, many of which are concerning, both to the physician and to the patient, and need to be recognized. Regrettably, for MDD, only about a third of patients achieve remission, with a similar number who obtain some benefit and a final third who are treatment failures. We have a lot of work yet to do in producing effective and safe antidepressant agents. So, with that, thank you for your attention. Please feel free to email me with any questions you may have about these materials. Thank you and goodbye.